Welcome everybody to the webinar called Bad Air Introduction to Outdoor Air Pollution Epidemiology by Dr. Will Mueller. Will Mueller is coming from the Institute of Occupational Medicine in the UK, and he's a chartered statistician. He has a lot of experience with datasets that represent various research fields, including population health of atomic bomb survivors, violence and injury surveillance in the Caribbean, and also interesting work on cognitive effects from mobile phone radiation based on the phone use in London adolescents. So it is very nice having Dr. Mueller in the series of the webinars that take place because of the Exposure Gas Horizon project. And we have periodically this set of seminars to further educate the students and also the researchers and the staff of the Cyprus International Institute for Environmental Public Health. With no further ado, Will, the floor is yours. We look forward to hearing to your presentation.
Great, thanks Konstantinos for the introduction. So that pretty much takes care of my first slide, which is just about me, a bit of my background. The only thing I'll correct on the introduction is that I'm not yet a doctor, but a current part-time PhD student at the London School of Hygiene and Tropical Medicine while working at Institute of Occupational Medicine, but hopefully I will be a doctor at some point next year. That's the plan. And my PhD is looking at green space and health, and specifically looking at potential pathways. So looking at green space and air pollution, and also green space and the opportunity for physical activity. So, okay, I'll just provide an overview of the presentation. I think my colleague Damien McElvany gave a talk on occupational epidemiology a few weeks ago, so I don't know how many of you attended that, but there might be some general overlap with epidemiology studies, but I'll be talking about air pollution, so there shouldn't be too much overlap, but if there is, that's okay, because repetition is good anyhow. So first we'll be talking about outdoor air pollution. So there's outdoor and indoor sources of air pollution, so we'll be mainly focusing on outdoor air pollution for this talk. So we'll go over the main sources and key pollutants that are part of outdoor air. Then talk about the key epidemiological studies, or the types or study designs specifically for air pollution studies and some of the key historical air pollution studies. I'll then talk about some of the health effects that are associated with air pollution. We'll go into how exposures can be reduced and some policy measures. And at the end, I'll discuss a case study in Thailand. So we have an ongoing project in Thailand looking at long-term health effects of air pollution, and we're also doing some work looking at exposure to biomass burning. So I'll talk about some of that work later on. As Konstantinos mentioned, we can have, I guess it's time for a question and answer period afterwards, but if anyone has any questions during it, feel free to ask at any time. So outdoor air pollution is actually a mixture. We think of sort of air pollution as a haze, or sort of generally, I suppose, when you see air pollution, the air is really bad. It looks as this sort of smog or brown haze, but it's actually a mixture, and it can be generally a mixture of particles, which is known as particulate matter, or PM. You may have heard the term PM before. And gases. So the key gases really are nitrogen dioxide, or NO2, which is predominantly from traffic, sulfur dioxide, or SO2, which is mainly from industry, and then carbon monoxide, or CO, is also emitted from traffic. Now those are primary gases. Now there can also be gases formed later in the atmosphere. And the main one here is ground level ozone, which can be formed from nitrous oxide, nitrogen dioxide, that's the NOx there, as well as volatile organic compounds, and that's usually in the presence of sunlight. Now, particulate matter itself is a mixture, and it can vary greatly by size, composition, as well as the surface properties. And particles can be from a number of sources, can be from combustion, so it can be from industry, can be from tailpipes, can be exhaust emissions. Even beyond emissions, it can be from brakes and tires from cars. As well, it can be natural dust, so there can be natural and anthropogenic sources of PM. And then as well, particles can form in the atmosphere. They can be nitrates and sulfates, or aerosolized nitrates and sulfates, which can form over long distances from gases. So there's a pretty big range of pollutants, actually, that can be in the air. So this is an electron scanning microscope image of particulate matter, and you have the scale there. So that shows 20 microns. So you see here that there's quite a mix of sizes, first off, of shapes. And so I think this is, it says here this is from Port Talbot, so this is a sample that was taken in Wales, and it's probably just a combination of sources. So you can see that it is quite a mixture that's in the air. So how do we measure these pollutants? It's typically done on a mass or weight per volume, units of micrograms per cubic meter. So that's also a concentration, and it can be measured over different time periods. So you may have an hourly average or hourly mean. It could be a daily mean, or it could be over longer periods, weeks, months, to years. So particulate matter, we saw in the previous slide, the different sizes and shapes. And so there's nomenclature that refers to the different sizes. So TSP refers to total suspended particles. So that pretty much captures all particle sizes that are in the air. And then you have PM10, which is inhalable, so you can breathe that in. PM2.5 is particles less than or smaller than 2.5 microns, and this is known as fine particle size. And PM2.5, those are the ones that have pretty much got the most attention recently, that have been included in epidemiological studies, typically included in regulatory limits. So PM2.5 is the main particle size that's been a focus recently. Also, more and more is looking at these smaller particle sizes, so PM 0.1, so particles smaller than 0.1 microns, which is in the nano range. That's known as nanoparticles and ultrafines. So there's also looking at the particle number, and so the smaller the particle, the higher number you can have, and you can have very, very high numbers. You can have more than 20,000 per milliliter. So that's also something to take into account, not just the mass, but particle number. So that's mostly what we've been talking about is for particles. Gases can also be done on a mass basis, but are also commonly measured in parts per million or parts per billion. So that's ppm and ppb. So another just graphic to kind of grasp the scale of PM 2.5. So this is the classic image. You may have seen it before, showing a human hair, and then PM10 particles. So there's 5 across there, which is assuming the human hair is 50 micrometers. And so PM 2.5 is really, really small, even just considering the size of a human hair rather. And so PM 2.5, part of the reason PM 2.5, these small particles are thought to be more harmful, is that they can drive deep into the lung across the alveoli and get into the bloodstream, and can have a range of health effects just getting into your system through that pathway. All right, we'll talk about some of the different types of epidemiology studies, most relevant for air pollution. So just the role or the purpose of epidemiology is to look at common diseases and to look at sort of risks and causes for different types of diseases, ill health, and death, we're looking at a population level. So it's not just looking at a few people who are ill, but it's looking at a population as a whole and seeing what the rates are of disease or ill health. Examples are some of the more common diseases, looking at cardiorespiratory disease and looking at different cancers. So a key sort of benefit or advantage of epidemiological methods is accounting for other factors that may increase the risk of disease. And so it could be individual factors, so age, sex, underlying conditions. So we really want to isolate the effect or the impact of, say, a given exposure like air pollution on disease. So it's important that we take into account some of these other factors. So with these studies, we can't identify an individual and say, this specific person was killed by air pollution. But what we can do is on a population level and for specific subgroups, we can estimate the risk disease. So we can say what's the percentage increase in deaths or hospital admissions or a given health outcome for a certain level of pollution. So we can say essentially what the increased risk was with air pollution for a given disease. We can also look at the impact in specific populations. So we can look at certain age groups, we can look at a subgroup with a certain condition or underlying illness and see what the risk is in them. And then ultimately also establish exposure response or concentration response relationships. So seeing what the risk is over different exposure levels, and it could be linear, it could change maybe higher or lower at higher concentration. So it's really trying to find out at what exposure levels are associated with specific diseases or increased risks of certain diseases. So there's sort of three key types of epidemiological studies that have been used historically to help determine causality of air pollution and range of health effects. And so they sort of build in sophistication. So the first were just air pollution episodes, and these were looking at really discrete or specific periods where there were high levels of air pollution. A classic example is London smog. Next is looking at time series studies. So this is looking at the same population over time, could be within a city, and seeing how variation in air pollution on a daily basis is associated with changes in health on a daily basis, and also looking at other factors that might affect health. And so typical outcomes in these sorts of studies is looking at daily mortality or the number of daily hospital visits or admissions. And then the last study we'll talk about or design is cohort studies. And this is looking at populations exposed over the long term to different levels of pollutions. And so an example of this is that you may have a number of populations in cities that have been exposed to different levels of air pollution over time, and you can compare what their health is like. So first we'll talk about the London smog of 1952. So this is in December of 1952. You can see on the left is a picture, and this is in broad daylight, or it was supposed to be broad daylight, just how poor visibility it was from air quality. So the graph here, you see that there's an increase, about for 5 days or so, there's an increase in this fog. So you had high levels of smoke and sulfur dioxide, and almost immediately with this, you had a spike in the number of deaths. So this was, you don't really need an epidemiological study to see this, but you can see that significant increase in deaths, which coincides very tightly with these increased concentrations of smoke and sulfur dioxide. And this is caused by, there's a temperature inversion. So you had this, a lot of people were burning coal because it was cold. And so you basically had a lot of this hot air and these pollutants that were trapped that couldn't disperse just because of certain meteorological conditions. So there was a policy response to this. It was fairly quick, and that was to just sort of stop the domestic burning of coal. So that was an important historic example of a specific episode, but there's been many episodes since then, and that sort of continue to this day. An example is the wildfires that happened in Greece in 2009, about sort of 10 years ago. So you can see here a satellite image of the fires, and so you can see where the smoke is quite small. That would be the origin or the source of the fire. You can see how large or how wide an area it spreads with wind dispersal, and you can see that there's multiple sites here, but seem to be in the opposite direction of Cyprus, so that's good. Another example that seems to be an annual occurrence now that you may have read about in the news end of last year is this crop burning in Delhi, India, that occurs around November. So typically you have farmers who burn agricultural residues to get ready for the next season, and it produces really, really high levels of particulate matter into the high hundreds of micrograms per cubic meter. So you have a picture here of just what the air looks like. So there's still episodes for various reasons that occur in different parts of the world. So episodes, they are important because of the such high concentrations that people can be exposed to in a short amount of time, and they tend to catch attention. The media likes to pick up these stories just to show how bad air quality can be. But actually, it's air pollution at the more ordinary levels, the day-to-day levels, that can cause actually greater health problems because you have a whole population that's exposed every single day rather than certain populations in specific time periods that may be subject to these higher concentrations. And so studies of these ordinary levels have shown actually that even small increments in air pollution can lead to more deaths, hospital admissions, visits to general practices, asthma attacks, days off work and off school, a number of symptoms, respiratory and otherwise, and actually the list keeps growing, looking at metabolic disorders, neurodegenerative diseases. It seems that the more air pollution is studied, the more you see diseases that are negatively associated with air pollution. So looking at ordinary levels, or these, excuse me, sort of more typical air pollution concentrations are time series studies. And they've been growing and evidence has been building with time series studies since about the 80s, and they're still done today. As I mentioned before, they're typically done in large cities. Large cities are good because you need a large population to study in order to distill the effects of air pollution, given all the other causes of disease. And so it looks at just short-term effects. It looks at day-to-day variation in concentrations and also day-to-day variations in, it could be deaths or hospital admissions or otherwise. And it can also include other factors that might affect daily deaths. So it might be the time of year, it could be temperatures, if it's very hot, can be associated with increased mortality. So it tries to control for these other factors. And there's a lot of time series studies actually because it uses routine collected data. So one thing with time series studies is that it doesn't look at individuals, it looks at collective populations. So it looks at the counts of, say, deaths or the overall counts of hospital admissions or visits to see how those are associated with air pollution. So there seems to be this triggering effect on days of higher particulate matter, or PM, with mortality. And so I mentioned that these studies have pretty much been occurring since the 80s. There's a large study that came out in August of last year in the New England Journal of Medicine by Liu and colleagues, and they looked at 652 cities in 24 countries over the period 1986 to 2015, and they were looking at mortality and PM 2.5. They found an average effect, an increase of 0.68% with a fairly narrow confidence interval there per 10 micrograms per cubic meter. So there's a 0.68% increase in mortality for every 10 microgram per cubic meter increase in PM 2.5. Now that's fairly small. I mean, it's less than 1% per 10 microgram increase. That's over a huge population, and that's, you know, over a long period. That's just shown in between 1986 and 2015, but there's people, you know, people are exposed to these levels every day. So even small risk can be quite significant when it's over a whole population. So they use 652 cities, but they also include a map of where the cities where they were included. And to be included, the cities need to have a monitor that measured PM 2.5. So this shows where they were situated. And right away you can see that there's many more places without than with. You see large areas, typically in the southern hemisphere, that don't have any coverage. You can see Asia around China, particularly in the east there, is well covered, and certain areas in the US on the east side, but there's many cities that don't have PM 2.5, so these results are biased towards those cities that have actually PM 2.5 monitors. So even though it was an impressive study in a large area, it's actually surprising to see how many places weren't included because they simply didn't have measurements. So what are the policy implications from time series studies? So there is some, I guess, contested or unclear impacts, and it's the fact that some believe that the risk of earlier death is believed to be in people with pre-existing serious diseases or cardiorespiratory diseases. And so instead of these people, I guess the issue here is that it seems that air pollution has sort of caused a death that would have occurred anyway. So it's just moving forward the deaths by a few days. And so we can look at this by looking at years of life lost. And so years of life lost would be much greater in people who are younger who died compared to someone who is older. So this is something that time series studies, it's difficult to look at. And the policy implications is to, well, is there a larger public health effect or impact to control the peaks, so the very high levels, or the average exposures? And these studies have shown us that there's really no evidence of a threshold. So we really need to control just the average levels on an annual basis. And so if you can bring down the average levels so that more of the time people are exposed to lower levels, then that will have the greatest public health effect. So the next study is looking at cohort studies. Now previously looking at specific episodes and looking at time series studies. So they just looked at counts of things. They didn't actually look at individuals. They just looked at sort of daily statistics. Cohort studies look at individuals, so they move this forward a bit and have actually data on specific individuals. So this has some benefits, and the two sort of game changer or seminal studies were done in the US, and this was the six cities study and the American Cancer Society study. So at the individual level, they were able to control for factors such as age, gender, socioeconomic status, whether people smoked. And then at the city level, they looked at pollution. So they looked at cities that included monitors, and then also incorporated the climate, region, and general deprivation of the cities. So the first one, the Harvard 6 Cities cohort study, it's 2 graphs here. So in a cohort study, you start with a population or a cohort of individuals, and you follow them forward through time. So the graph on the left here shows the probability of survival. And so at the beginning, with 0 years of follow-up, is 1, because, well, everyone is alive at the time that the cohort was set up. So they're looking at mortality, and so they followed them up over time. It looks like they were followed up for 16 years. And the y-axis shows the probability of survival. And you can see that on average, the probability of survival was quite different in the 6 studies that were included. There's definite differences when you look after 14 to 16 years between the cities. And so you think, okay, well, is this related to air pollution at all? And on the right, you can see that it's very much related to air pollution. And the city P, which I suppose is Portage, has the lowest average concentration of PM2.5, or also known as fine particles. So the other cities, you can see, the rate ratio is basically the mortality rate in the other cities compared to the city with lowest air pollution. And you can see that there's this linear trend that the cities with higher concentrations of fine particles have higher mortality. So this was pretty clear. And actually the risks for exposure to long-term air pollution are higher than these day-to-day risks from air pollution that we saw were quite low. They were smaller than 1%. So that was an important finding. That hadn't really been shown in individuals and in multiple cities like this over time. The American Cancer Society study provided some more information looking at specific types of mortality. And from this, we can see that a lot of the increases in all-cause mortality, important outcomes are, or causes of mortality are cardiopulmonary and lung cancer. And the scale here is log relative risk, so it's a bit confusing, but 0.1 is basically a 25% increase. And so you can see that it may not be completely linear, but you see that there's definite increases in risks for these particular causes of mortality with increases in PM2.5, even at relatively low levels of PM2.5. So just to summarize from these 3 studies, or 3 study designs, we saw from the 1950s that air pollution episodes can cause increased death and ill health in the same day or days immediately following. From the 80s onward, we could see that daily pollution, even at normal levels, can cause increased death and ill health, and that there's actually no known safe level or threshold for the population. But with this, more so we saw that air pollution would increase risks among people with pre-existing diseases. Then from the 1990s onwards, with cohort studies, we saw that there's an increased risk of mortality with PM2.5. There's also been studies done on NO2 and ozone. And with this, there's no safe level. The risk is not just actually those with pre-existing disease, but for the whole population. And now there's believed to be an average risk of about 6% increase in mortality in age-specific death rates. So those are the 3 key studies or study designs that have really helped link our knowledge of air pollution and different types of health. So we can look at different exposure strategies, and from what we learned in the different study designs that, well, episodes and hotspots are important. Largest gains can be from reducing average exposure across the population, so not just on high pollution days or in high pollution areas, but really for everyone, as well, people are exposed to air pollution every day. So one thing that I haven't discussed is actually inequalities of the risks of air pollution. And so there's two key points here to take into account. One is inequalities in the relative risk. So risks with air pollution is typically on a percentage change in health effect per unit pollution. So there could be different risks by age or by gender. And the ACS study, the American Cancer Society study, the second cohort study that we looked at, it actually found higher mortality risks with lower educational status. So that would be a higher percentage change in the health effect for unit pollution. So the first bit of health inequality is that the risks could be larger for certain groups, and it tends to be larger in those of lower SES. And the second bit is the importance or significance of background rates. So the background rate of mortality is not equal in all populations. In fact, it tends to be higher in people of lower socioeconomic status. So even if the risk from air pollution was the same in all populations, it would actually have a bigger public health impact just in populations that have a higher background rate of mortality anyway. Never mind there actually being greater risks for those specific subgroups. So those are just two key points to consider, that air pollution may have a different effect, could have a larger effect on certain subgroups, and even if the risk is the same, it'll have a larger effect on groups that have a higher background rate of mortality anyway. So one point here is, there's been research on air pollution for decades. So you can think, well, why are we still doing research on air pollution? We know it's bad. Why are we still spending time and resources and efforts on studying it? Well, it is important because there's a lot of different types and sources of air pollution. There's different types of pollutants. So really need to look at, well, which are the most harmful, and make sure that those are prioritized and targeted for regulation. And so one underlying or continued research question is whether primary particles, so those that are emitted directly, are more harmful than secondary particles, so particles that can be formed over time, over long ranges. And so expert groups still haven't been able to determine whether certain particles are more harmful. And with that, it's not possible to quantify these differences. So there's still ongoing research, and the purpose of this, as I mentioned, is to try to determine which sources of air pollution are most harmful, to make sure that those are targeted for interventions. So also, air pollution is not just a local issue. So certainly local emissions can have a negative effect on local public health, but pollution travels. And so there are these secondary particles that can be formed from nitrogen dioxide and sulfur dioxide. They can interact in the atmosphere with ammonia as an example. And so in the UK, actually, local emissions really only account for about 50% of the effects of nitrogen dioxide and SO2. So it goes both ways in that you have local emissions that are important, but that a significant proportion is from elsewhere. Likewise, local emissions will also go elsewhere. And so it's a global issue. It's not just a local problem. And it's similar to climate change in the sense that, everyone is sort of in it together. And so local measures are important to undertake, but actually there needs to be this cooperation. And even just looking in the UK, so sure, there was Brexit. We left the European Union, but we're still getting, poor air quality or particulate matter from the EU. So, these things need to be coordinated on sort of a large basis. Otherwise, you can take into account local measures, but they may not be sufficient to really improve air quality. So just to summarize, so everyone's exposed, we know that every day. There isn't a safe level. It's not just trying to control hotspots and pollution episodes. And that there's this really, the larger health effects that we see from cohort studies is from this long-term exposure to pollution, not just these sort of higher episodes that occur. And the important bit is that it's not just local, it's actually on a much larger scale. So it really is, it's a difficult issue to try to tackle. And that's why there's so much focus on air pollution, why there's so much research on this. So the final bit here is we'll look at this case study in Thailand that we're working on, looking at exposure to biomass burning. So Thailand experiences really high particulate matter concentrations from crop and forest burning, and it occurs during pretty much this time of the year from February to April. So I've shown a map here, and this is from the firm's NASA website. So it's a satellite image showing the number of fires. And so these are the number of fires in February of this year. And the legend here is yellow just means that there are not many fires, and red means that there are over 100 fires. And I don't know if you can see my cursor here, but this region here is Thailand. This is the north of Thailand, so you can see that there's really high density of fires that took place in this region. And again, it's not just local, it's not just fires in Thailand, it's actually in the whole region here. So we're looking at whether the risk from exposure to particulate matter from biomass burning, how that relates to the risk from particulate matter from traffic-related particles. A lot of the research that's been done historically is in urban areas where much of the PM is from traffic and industry sources. So this is a different source. So we want to see how the risk compares to that from typical or traffic-related air pollution. So we looked at hospital visits as the health outcome and looked at PM from biomass burning as exposure. So the study area was just the north there, the sort of hotspots of, or the epicenter of where the biomass burning occurs. And the black dots show where we had particulate or monitors of PM or particulate matter. We also collected data on carbon monoxide, nitrogen dioxide, and ozone. We looked at 3 different types of hospital visits. It's chronic lower respiratory disease, ischemic heart disease, and cerebrovascular disease, because those seem to be most sensitive in the short term to air pollution exposures. So this is a time series study, so you guys now know what a time series study is. So we looked on a daily basis over 2014 to 2017 and looked how the concentrations of PM changed on a day-to-day basis and related that to changes in hospital visits. We also wanted to see effect modification. So we wanted to see if there was a change or a difference in risk from exposure to biomass burning, but it was hard. It was a bit difficult or a challenge to try to identify when someone was exposed to biomass burning. So we used the 99th percentile of PM10 levels. So we said, okay, we know that on days of high PM levels, on days of very high concentrations, we know that it's likely that they were exposed to biomass burning. So we assigned certain days or days of this high levels of PM10 to biomass burning to see if there's a difference in average risk from non-biomass burning days. So more typical or traditional sources of air pollution or particulate matter, and compare that to PM specifically from biomass burning. So on the left, this is the daily counts of respiratory emissions. And so you can see there's this ebb and flow. There's these peaks and troughs that occur during the year. This is during the study period, so it's from January 2014 to the end of 2017. And on the right, you can see that coinciding with this biomass burning period from February to April, you have very high concentrations of PM10. And this period of the year is also the dry season. So the dry season in other places has higher concentrations anyway of PM10, but they're really driven up higher by this biomass burning that takes place in other parts of the year or other times during the year. You can see that the concentrations are much lower, and this trend is shown for pretty much each year, although the peak in each year can be different. So this shows the risks for the three different types of hospital visits, and the different dots. So that's the point estimate of the risk coefficient, and the line just shows the 95% confidence interval. So we didn't just look at exposure to PM10 on the same day. We actually looked at exposure to PM10 on previous days to see what the greater effect was, to see, is it air pollution exposure on the same day that is associated with adverse health, or is it on a previous day? And we found actually for each of these health outcomes, we saw that there is the largest risk on the same day of exposure. And it was statistically significant for chronic lower respiratory disease and cerebrovascular disease. There was an increase for ischemic heart disease, but you can see that the confidence interval crosses 1, so it's not considered statistically significant. And so the y-axis there, it says IRR, so those are incidence rate ratios, but the values there can be interpreted as percentages. So the first one, for instance, is chronic lower respiratory disease, and the dot is between 1.01 and 1.02. So the risk is pretty much between 1 and 2%. So there's a 1 to 2% increase in chronic lower respiratory disease hospital visits for every 10 microgram per cubic meter increase in PM10. And just to reiterate that, the largest risk and pretty much the only statistically significant risk was on the same day of exposure. So we wanted to compare between days of non-biomass burning and days of biomass burning, and we found actually that there were only significant risks on days of non-biomass burning, and that was for chronic lower respiratory disease and cerebrovascular disease. And it's not to say that there wasn't a risk for ischemic heart disease, but just that it wasn't statistically significant. So this was an interesting finding, but it could be for there's sort of a couple of reasons that it might be that we didn't find an increase associated with biomass burning. And it may be that there is less data because we just used the 99th percentile of PM10 values, that we didn't have enough statistical power to identify whether those exposures were statistically significant. But also that the effects of air pollution tends to be a lower risk at higher levels anyway. So even though we wanted to try to tease out the risks from biomass burning, well, you only have risks from biomass burning at these higher exposure levels. So we found that the risk was slightly lower, but we're still not quite sure if that's actually from biomass burning, or if that's just because that the concentrations are higher and they're typically lower risk at higher concentrations anyway. And that's to say that the risk level is lower at higher concentrations, rather than there being a lower risk at higher concentrations, which is kind of confusing. Anyhow, this work we've submitted it, is under review. So we're still waiting to hear back on that. And we're also looking at exposure to PM10 during pregnancy and looking at effects on birth weight. So finally, this is the last slide I have. So future areas of air pollution epidemiology is looking at personal exposures. So trying to not just look at the monitor of a city or citywide exposures, but looking at what people on an individual basis are exposed to, both indoors and outdoors. Assessing differences between sources, so different sources of PM 2.5, looking at research or expanding research to developing countries where there hasn't been as much research or as much coverage in PM monitoring, and also looking at some novel health endpoints such as birth outcomes, diabetes and other metabolic disorders, and neurodegenerative diseases such as dementia and Alzheimer's. So that's all I have. Thanks for joining. Happy to take any questions now, or feel free to email me later. There's my email address there. So thanks.
Thank you. Thank you very much, Will. Very interesting presentation. It allowed us to, as we said, dwell once more on the details of the exposure assessment first, and then you actually provided the epidemiological evidence that link exposures to particulate matter with a series of cardiovascular disease outcomes. I have, maybe I can ask a question first. I wanted to ask you a more specific question first that relates to the methodology of your analysis. In effect, I wanted to ask you, maybe I missed it in your study design, but did you account in the analysis in these models that you showed for the spatial location, the areas that you incorporated in the models? Because I sense both the exposure and the outcomes come from different regions in Thailand. Did you try to see if some particular areas were driving the relationships you were seeing overall?
Yeah, so we looked at province level exposures. So we had basically just a couple of monitors in each province. And with the data that we had, the health outcome data, we knew which province people were from. We didn't know where exactly they lived in that province. So we just provided a daily average exposure estimate to each province. And so we looked at specific province exposures and province health outcomes. So that would help take into account any differences in background rates in the different provinces, because we were looking at, it was a time series study, so we were looking at the changes in health outcomes over time associated with air pollution. So it's like each province basically is its own control. And so we look at whether the increase in health outcome is significant with increases in air pollution. And we looked at visits specifically for, we separated by sex and also by age group, which I think was just less than 65 and over 65. So we were somewhat limited with the data that we had available, but we tried to take into account these different provinces. And actually, we had data on other provinces, but there were gaps. So we also included provinces that had less than 25% missing data over the study period, because you want to make sure that you don't have large gaps in your pollution, because you want to sort of include as much as you can and not miss any important fluctuations over time.
Mm-hmm. Okay. So the daily average for the PM that you use as your exposure metric, do you think there could be another modeling way to actually incorporate the variation that you would expect to see within the day for the PM values instead of taking the average?
Within the day, so yeah, so we took daily averages. You could take daily maximum. You could take the median. For ozone, actually, what's typically done is the 8-hour rolling average. And so you calculate this 8-hour average of ozone, and then you use the highest 8-hour average as the daily value for ozone. And I'm not sure if we looked at medians as well for PM values as a sensitivity analysis, but I don't think it actually makes a significant difference. I think you still get similar results, but it might be something to look at actually. And as I said, the paper is still under review, and so we're sort of keen to get some feedback from other reviewers to see if there's any other ways to model this or to look at this.
Sure. Yeah, the case study is very interesting because I sense your Thailand case study might be one of the few, or maybe the first one that looks into these associations. So I'm sure it will attract some attention.
Yeah, there's been a couple of other studies in Thailand, I think in Bangkok and some work in the north, but we had a good amount of data actually, had a few years, a number of provinces, and so we were able to detect some effects. And there's quite a large discrepancy or difference between the PM levels during the burning season and then during the non-burning or the wet season. And so you can really detect some effects here. And actually in the discussion, so I didn't mention this here, but the risk levels seem to be similar to those in other studies. So although we didn't see a difference on just specifically those burning days, it's likely that we were extra conservative and so assigned the burning days on too few days, whereas pretty much people are probably predominantly exposed to PM from biomass burning during February, March, and April. So that was sort of a thorny methodological issue. But anyway, the sort of output from our studies, the risk outputs were on par with other time series studies looking at hospital visits.
Mm-hmm. Okay. Any other questions, comments from the audience? Feel free to ask any question you might have to our speaker. Yes, anyone? Maybe some people are muted and we cannot hear them.
So I can also just...
There you go.
Hi, sorry, let's
I can hear you with an echo, Corina. Maybe you need to... You have two sources of audio.
Hello, I
Now
just wanted to ask
Okay.
about the, thank you very much first for your presentation, for your webinar. You said before about the safe limit for the general population that there isn't one. We know that there are some guidelines from the World Health Organization about the limits, let's say that they need to be kept. Do you think in the future we could do something for sensitive populations to have some other, let's say, limits, or I don't know, let's say some more specific guidelines for these sensitive subpopulations?
Yeah, I think that's a good point. And sorry if I said that there weren't limits. So you're right that there are limits. There's the World Health Organization prescribes daily and annual limits. So for PM 2.5, the daily limit, I can't remember off the top of my head, but I know the annual limit is 10 micrograms per cubic meter, which is quite low. And I'd say that most places are probably beyond that, or above the limit. And so whether there should be lower limits for more vulnerable populations, probably on a practical basis, I think it's more important to sort of drive down average concentrations. So if we can get to some of these places with average higher levels to get just to lower levels, down to the 10 or perhaps around the 20 margin, then I think we can look at perhaps specific limits for vulnerable populations. But I think the important thing is getting, concentrations lower for everyone into current limits. And I think the WHO is actually revisiting their limits to see if they need to be lowered. So that actually might be one thing that they're looking at, is having separate limits for vulnerable populations. Yeah, it's a good question.
Thank you, Corina.
Yeah.
Any other questions?
Hi, this is Alina. Thank you for the presentation. I just wanted to ask you, do you have any idea, or did you do any studies with regards to the cost, the actual money associated with this association with the high pollution and more hospitalization, more use of the healthcare systems overall? Do you have any numbers to show us?
So I don't have any numbers, but we are doing a health impact assessment as part of the work in Thailand. So we'll be doing a health impact assessment of long-term exposure to air pollution. And so what I presented here was an epidemiology study. So that's looking at concentrations and health outcomes and trying to quantify what the risk is. A health impact assessment, you're looking at concentrations at a population level, and then you're estimating what the health impacts would be from those concentrations. And then with that, you can also estimate the cost of health impacts. So there are average costs associated with hospital visits, days of lost work, even with mortality. So I think we'll probably come out with some estimates once we do the health impact assessment, but that's sort of still in the process right now.
Okay, we're looking forward to it then.
Yeah, I can circulate actually this study, the time series study that I mentioned. Once that's published, I can send that to Konstantinos, as well as a health impact assessment, which we're hoping to finish this summer.
Okay, can I ask you something else? You said, of course, and I agree with you, that it's not just, let's say, something local, it's something that affects the whole world. So measures should be taken worldwide. But let's say if you were asked to make a suggestion of how to move forward with regards to all this data that we have in terms of policy, what would you suggest? What would be the first step in this effort?
That's an easy question. No, I think it needs to be coordinated, but it also depends on where the significant or largest sources are for different regions. I mean, some places will have traffic. I mean, cities, it'll be predominantly traffic and industry. So if cities can implement better emission standards, offer better transportation, crack down on industry, have better regulation. The crop burning issue is really a difficult one, and it affects people in a number of different regions. And people burn the crops because it's an easy way, I think, to get ready for the next year, and it's cheap. And so I think governments have been wrangling with that as to come up with a better alternative. And it's also very difficult to enforce if you have a ban on burning, because it's, a large area. So I'm not sure. I think it needs to be sort of a multi-pronged approach. And I think there needs to be some consistency and, regulation to drive, reductions in emissions. Because if there's no you know, if there's no policy, then there's less of an incentive for industry and people to change.
Yeah.
Hello guys.
Hi there.
Hi guys. I don't know if you can hear me.
Yes.
We can hear you.
Okay, I have a question. Thanks for your presentation, by the way. You mentioned you assessed health outcomes. So I wanted to find out what data did you use to see the impact of this air pollution on health outcomes? Was it like you went to the hospitals to check their records, or what was it that you did exactly?
So that's a good question. So for Thailand, we have collaborators working in Thailand at Mahidol University. And so they collected the hospital visits from the Ministry of Public Health. So hospitals in Thailand have an obligation to report this sort of data to the Ministry of Public Health, who then collate and summarize this. And so we put in a request for data to the Ministry of Public Health. You know, you have to say what you're doing, what the research project is, why you're doing it, and then they'll release the data. So that's how we got it. And it's important to get these sort of national level data to make sure that it includes, you don't have any missing data and it's inclusive as possible. It's difficult there because they have private and public hospitals, and I think both are obligated to report, but I'm not sure if all the private hospitals necessarily report. But yeah, to answer your question, we received the health data from the Thai Ministry of Public Health.
Oh, okay, thank you very much.
Sure, thanks for the question.
Well, many questions on the floor. It was a very interesting talk. Thank you very much, Will, for the very nice webinar.
Yeah, thanks very much for inviting me to do it.
It was our pleasure having you, and we wish everybody stay safe, stay sound with the coronavirus. And we will be back again soon with another webinar series for CII. Thank you and have a good day.
Great, thanks very much. Bye-bye.
Bye.
Bye.